Donc, bonjour à tous. Enchantée,
Hello,
ça me fait plaisir d'être à la session
I'm
ce soir.
pleased to be
Je m'appelle Marie
here.
Baudin, je suis
I'm Marie
neuropathique
Baudin.
spécialisée en
I'm
maladies neuromusculaires
specialized in
chez Québec
neuromuscular
Hôpital de l'Enfant
diseases.
Jésus,
I'm in
ainsi
Quebec
qu'avec
City's
ma
Hôpital
formation
de
en
l'Enfant
neurologie. Donc, c'est ça
Jésus,
qui m'ont
where I did
surspécialisée
my
en maladies
training in
neuromusculaires à
neurology
l'Université
and my
Stanford, où j'avais aussi
specialty as well
travaillé
at
principalement sur les
University
maladies
Stanford,
auto-immunes,
where
notamment les
I
neuropathies
worked
chroniques
on
l'affection des
autoimmune
neuromuscles.
diseases.
Voilà, donc c'est un petit peu ça mon parcours. Puis j'ai un intérêt
So
clinique
that's
entre
what
autres
I
et
did, and I have a
recherche pour
clinical interest and a
l'immunothérapie et les
research
traitements
interest on
inflammatoires
risk
en conditions
factors
auto-immunes.
and treatments.
Donc, bonjour à tous, moi c'est Vincent
My
Piché-Martel.
name
Je suis
is
un
Vincent
neurologue spécialisé en maladies
Pichet-Martel. I'm a
neuromusculaires à CHU
neurologist
Québec.
specialized in neuromuscular
J'ai
diseases
commencé ma
at
pratique
CHU Quebec City.
cet été au mois de juillet.
I started my
Comme
practice
Marie
in
Baudin vient
July,
de se présenter,
and
j'ai fait ma formation à
as
Québec
Dr.
et je suis
Baudin, I was
parti
trained
2 ans
in
en
Quebec City,
sous-spécialité à
and
l'Université Harvard
I
à Boston,
trained at Harvard
où
for
j'ai
2 years
fait
for my
une spécialité en neuromusculaire et également
specialization in neuromuscular diseases.
chercheur clinicien
And
judiciaire du
I am
Québec.
also a researcher and a
Je me
clinician
concentre
here in
en
Quebec City.
recherche principalement sur
I
les
focus on
pathologies et les
research
dystrophies musculaires, mais en tant que
on
spécialiste en
muscular
neuromusculaire,
dystrophies.
je vois dans ma pratique
And
différents
I
types
also
de
see a
patients.
lot of neuromuscular patients in my practice.
And I'll now invite our other panelists to introduce themselves, and then we can begin the Q&A. So we can go with Dr. Beaton and then Dr. Vassar.
Hi there. Nice to be here. Thanks for the invite. I'm Katie Beaton. I am a neuromuscular neurologist in Vancouver, BC. I did part of my training here in BC and then a fellowship at the Rare Neuromuscular Disease Center in Paris, France. And I'm looking forward to hearing your questions and answering them as best I can.
Good afternoon, everybody. I'm a pediatric neurologist, neuromuscular specialist at the Hospital for Sick Children in Toronto. And I have looked after pediatric CIDPs and GBS patients for the last 35 or 40 years, maybe. And at any given time, with my colleagues at Sick Kids, we have about 10 to 15 CIDP patients. So I'll be happy to answer any questions which relates to pediatric CIDP patients.
Well, thank you all for introducing yourselves. We're all very eager to hear your answers and to hear the interesting discussion that we're going to have. So we'll start with a few questions in English, and we'll alternate back and forth between English and French. So feel free for the participants to ask your questions in whichever language you prefer. So our first question is for Dr. Beaton. So as a longtime participant in support group meetings, there seems to be an increasing amount of patients who are initially diagnosed with GBS being re-diagnosed with CIDP. So there's two kind of questions. The first question is, are neurologists seeing an increase? And were they always CIDP?
That's a really good question. So what we refer to is subacute onset of symptoms. So those people who fall into the time frame of symptom development in that 4 to 8 week category, we're never really sure if they're going to end up being a monophasic illness like GBS or if they're going to be a chronic illness such as CIDP. And it's a bit of a pattern of practice dependent, sort of where you are, whether you treat them for 3 months or just treat them once and see what happens. I think these patients have always existed. And personally, in my practice, I haven't seen that there's been an increased incidence of people who initially I think are GBS and then end up having CIDP. That's something that we've sort of seen all along. Sorry, I am at home with 2 children. You may have just heard a giant bang in the background. One thing that we are more aware of now, though, is these nodal perinodal presentations of inflammatory neuropathy. And I think Dr. Katzberg spoke to a little bit about that in his session yesterday. And we know that these patients can present in a more acute fashion, but then have a chronic illness associated with that. So not that it's necessarily increased over time, but I think we're getting a bit more of an understanding. So I think that was the first question. And then, sorry, was there a second part as well?
I think that kind of answers the question about whether there's sort of an increase that you're seeing, or if, and also if patients who maybe started out with GBS, but then they turned out to be CIDP, that's sort of monophasic versus chronic.
Yeah, and it really is, it's sometimes difficult to predict. There are a few things that we think make us think it's more likely to become a chronic illness, but a lot of the time it is, unfortunately, a wait and see sort of approach.
Mm-hmm. Is there anything that you see in let's say a GBS patient or a presumed GBS patient that makes you think maybe this patient doesn't actually have GBS, maybe it'll turn out to be CIDP?
Oh, that's a good question. So going the opposite direction. I don't think so. We know that patients who end up having the more chronic version are less likely to have things like cranial nerve involvement, so weakness in the face or difficulty with swallowing or difficulty with breathing. But more mild versions of Guillain-Barré can also present without those symptoms. I would say if there's a patient who was progressing on the slower end, because a lot of our GBS patients, it's a day-by-day change in their symptoms. But if we're hearing that story that it's more of a 1 week to the next week that they're seeing those changes and they don't have any cranial nerve involvement, then that might make me slightly more suspicious. But it is often difficult to tell at the beginning, for sure.
Thank you. Our next question is for Dr. Vassar. Is subcutaneous immunoglobulin being used in kids?
It's not easy to obtain really access to home care for pediatric patients to receive subcutaneous IVIG. We have done it only in one case so far, and it wasn't a patient with CIDP. We used the organization called One Help, which is a cross-Canadian organization, and so it can be organized. It's not the easiest way to do it, like for example, in the adult world, it's much easier to access the home care, healthcare providers. But it can be done. So we don't do it too often. We have done it in one kid so far.
Thank you. On va maintenant passer à une question en français pour le docteur
A question in French now. It's a bit of a longer question that I'm going to read. I was prescribed a high dose of gabapentin for pain during my GBS recovery. After years of being on it, I asked my family physician whether I needed it anymore, and they didn't want to handle dosing or weaning me off from that medication, because it wasn't that doctor that prescribed it to me. So what can I do? When can I know that nerve pain medication is no longer necessary? So thank you for the question. So pain medication, yes, eventually you can try to wean yourself off. Generally depends on clinical symptoms. When there's no more pain that's present, so generally we have to wait a few months or a year or two before weaning yourself of the presentation. If your doctor is not comfortable with that, there are other possibilities. If you have access to the neurologist that treated you recently, that's an option. In my practice, I think that pharmacists are really helpful in that respect. They have some freedom in terms of weaning off someone from the medication, or at least lowering the dose. So that's a possibility with a pharmacist who can help you over a few months. And sometimes if you have a doctor, there can be other doctors like rehabilitation, medicine, physicians. So you can, it's not necessary to keep taking pain medication if you do not have any more pain. So are there contraindications in terms of lowering a dose or completely weaning yourself off? No, I don't think so. There's no contraindication like medication like gabapentin and others. You have to go gradually with some medications, but you can actually wean yourself off the medication eventually. Thank you. Next question to Dr. Baudin. Would you recommend acupuncture for pain? Are there other treatments that you would recommend? What about hypnosis as a potential treatment? Could this help with nerve regeneration? So there are two parts, pain and then nerve regeneration. Yeah, can't hear you now.
Excellente question.
Okay, very good question. So, in immune neuropathies like CIDP and GBS, we have to distinguish the substantial treatment for the disease with IG or plasmapheresis versus other symptoms, residual weakness and other symptoms and presentations. Now, if we, for pain, for example, someone who has an optimal treatment for their condition, and there are a number of therapeutic options. What I use as a first line is drugs and medications that have good evidence. For example, gabapentin, duloxetine, and so on. So there are different drug options, but patients can be interested in non-pharmacological options like acupuncture. So first of all, I would say that there's no specific evidence for GBS and CIDP. As far as acupuncture is concerned, we can perhaps extrapolate from literature on neuropathies in general, but there are limitations because the underlying mechanisms are different. But let's take acupuncture first. If we look at neuropathic pain, there is pain linked to chemotherapy in cancer treatment. So for acupuncture hypnosis, we do not have large studies with control groups so that we can control with the placebo effect. So we cannot warmly recommend them, but acupuncture give us some evidence. For example, neuropathic pain from chemotherapy, some patients can see an improvement in their pain scores. Hypnosis now, there's even less evidence. When I was trying to do some research on that, so there are very few dedicated studies with good cohort and good controls in terms of neuropathic pain. But a lot of patients are interested in those kinds of treatments. If you're interested in them, of course, you have to make sure it's safe. Generally, acupuncture and hypnosis are safe options, and it shouldn't be too costly. If it's not too costly and put you in a difficult financial situation and you want to try them, then some patients can find some benefits with the limitations I've just mentioned. We do not have a lot of studies, so it's not something that I would recommend in my practice, but it's not unreasonable for patients to try them. Another question you said at the end of the question? Yeah, treatments to encourage nerve regeneration. So that's another chapter. We're coming back to the substantial treatment of the disease. Can acupuncture and hypnosis help in order to help someone really heal? In the literature that we have, there's no evidence that acupuncture and hypnosis can help nerves heal. But what you want to do is treat the underlying condition. So I think acupuncture and hypnosis are more treatments for some symptoms or the management of pain management, but they're not going to treat or heal nerves, and there's no evidence showing that it could regenerate the nerves.
So I've asked a round of questions to each of our panelists, and we want to make sure that we're having discussions around the questions. So even though I'm directing a question to one panelist, I invite you all to chime in if you feel like there's something you'd like to add, or if you want to have a discussion around a specific point. I think it would make for some really interesting discussions, and maybe new questions might come up that way. So we'll switch back to some questions in English. So Dr. Beaton, is there validity in testing severe GBS cases for contactin 1 or NF155? Would that knowledge alter the course of treatment for those patients?
I think that's an excellent question, and I think it's one that we don't have a complete answer for yet. The fact of the matter is that these tests take time. So even if they are available in your center, they're not going to be available that day or the next day. So we're going to have to treat the patient in front of us without that knowledge, at least in the short term. The place where I see them to be the most useful is in those patients where we're not seeing them respond to therapy as we would like them to. So those patients who don't have any response to IVIG, or specifically are continuing to decline beyond that first couple of days after we've given the IVIG, and we're really worried about that patient, or someone who's having a really prolonged course and not seeming to turn around a little bit. In terms of if it would change our treatment strategies, what we know is with the nodopathies, they are less likely to respond to immunoglobulins than those patients who do not have nodal or perinodal antibodies. That being said, many of them do still respond. And so even if we knew that they had an antibody present, they likely still would be treated with IVIG first, because it's safe, because it's available, because we're able to give it pretty much right away. But if patients are not responding as we expect them to, and we are able to identify an antibody early, then at least for me, I would definitely move to one of our, I would escalate immunotherapy faster than I would for a patient that if I didn't know that they had an antibody present. So for instance, we'd move to the B-cell suppression therapies such as rituximab, if we knew that they didn't respond to IVIG and had an antibody present. The real challenge right now is in access to that testing. So in my province right now, you have to basically pull teeth in order to get them to pay for that testing, unfortunately, even though it's done at my center. And in other places, it's much easier to access. So I don't think we're going to see widespread testing of nodal and perinodal antibodies in the acute phase of GBS soon. But I think we're probably going to be using it more in the realm of CIDP, and hopefully we'll get better access for those patients over time.
And this follow-up question, could be for anyone on the panel, because we're all from different places in the country, and things are often done differently depending on where you are. But how are you seeing these tests trending? Do you find that we're using them more and more? Do you expect that we'll be using them for all the GBS patients or all the CIDP patients, or do you want to reserve them for certain types of patients specifically?
Go ahead.
Je peux peut-être parler pour le Québec.
Maybe I could speak for Quebec, or at least in Quebec City. It's fairly easy to obtain a test, for example, paranodal antibodies. But I agree with Dr. Beaton. I think that tests should be reserved to refractory cases when there's no good response to plasmapheresis or IG. And in my case, I would use it in the cases of CIDP, but and also for the GBS patients who do not respond or not as well. And generally, we can see that and have a response or a result in about 3 or 4 weeks.
Merci, Dr. Piché-Martel.
Thank you, Dr. Piché-Martel.
It's still related to antibodies, and it's for Dr. Vassar. So in the pediatric world, are there cases of autoantibody variants in kids? And are you born with these autoantibodies present?
Well, I'll answer the second question first. Obviously, the antibodies are acquired as the child gets older and older, is exposed to different antigens and eventually develops these bad antibodies which will fight the peripheral nervous system, the nerves. We are not born with these antibodies, so they are not genetically predetermined. And in the pediatric world, we haven't done any really. Nobody in the world has done any major testing of these NF155 and all the other antibodies. So I think it's still a way to go, and it's a bit of a gray zone for the pediatric patients at this stage. I don't know if anybody on the panel has had any children and tested for these antibodies, but we haven't done it at sick kids.
Yeah, it sounds like it's an area of research and still some questions there. And there's always some challenges when there aren't that many patients that have these conditions to do these studies and investigations. So we'll definitely keep an eye out. Hopefully these studies get done, so we have some answers regarding that. La prochaine question est pour... Yeah, Dr. Vassar, if you had a follow-up, please.
No, not really. Thank you.
Thank you. La prochaine question est pour le docteur.
Next question for Dr. Pichet-Martel. Question is as follows. I have CIDP. I was stabilized on IG every 2 weeks. I'd like to know more about the plasmapheresis treatment. Is it plasma transfer, and can it replace IG treatment? I feel good, but if there's a possibility of remission, I'm open to trying it. That's a very good question. Plasmapheresis is really plasma transfer, which the idea is to remove IGs or antibodies that we have in our blood that we believe attack the nerves, and antibodies are in the plasma, so we replace the plasma with antibodies. We replace it with a protein solution. There's a plasma exchange that is done, and we have no evidence that plasmapheresis is better than IG. We think that both are equivalent. There have been studies that compared both therapies, and often both therapies had the same efficacy. So you wouldn't say that replacing IG with plasmapheresis could lead to remission in a patient where a plasmapheresis works well or IG works well. We tend to favor IG. It's easier because plasmapheresis, you need a catheter, you need a kind of entry port, and there are risks of infections, and it's not easy. It's not comfortable for patients, and you need more advanced facilities as well. Not all the hospitals do plasmapheresis, but IG is easy to administer everywhere. So to answer the question, I do not think that there is more hope in changing from IG to plasmapheresis in order to encourage remission. We move to plasmapheresis for people who do not respond well to IG in GBS. Thank you. So with that type of patient that is stable on some treatment, for example, IG every 2 weeks, after some time, do you try to change the therapy to see if there can be an even better response, or do you think patient is stable, should stay on this therapy, and as long as there's no deterioration, there's no change. There shouldn't be any change. So it depends on the patient history. I would say that in my practice, when we have IG patients every 2 weeks, we tend to, if they're really stable and the disease is controlled, we try to make IG administration less frequent, for example, every 3 weeks or every 4 weeks, and see how it goes, or even 6 weeks in some cases, with a stabilization with another medication. Sometimes it's possible to stop IG. We'll talk about it in another question later on. And it's the same thing with plasmapheresis. There can be corticosteroid medication. You can lower the dose, which is the objective in some cases, to lower the dose. So if it's a patient that's stable, we try to make the IG administration less frequent. Now, Dr. Baudin, if you've had GBS or CIDP, are you more susceptible to developing other autoimmune diseases? That's an excellent question. So generally, in terms of autoimmune diseases, we see it frequently. There can be comorbidities. But that being said, the data that we have in terms of CIDP is not something that happens very often compared to other autoimmune diseases. We have perhaps some conflicting data. There was a Dutch study showing the percentage of patients who had an autoimmune disease. 49% could have another disease. And then there was an Italian study which was actually polling questions, showing that there might be a higher risk for patients to have than another autoimmune disease. The disease that we see more frequently that's associated with CIDP is diabetes. We see it in a number of repeated studies, more patients with CIDP that also have diabetes. And there's also difficulty in diagnostic because there can be overlap between a different kind of neuropathy and CIDP. And so there are different issues in order to see whether there is an association. So I would say, to conclude, that the disease with which there's a lot of autoimmune comorbidities, although we do not have a definite response, is CIDP.
Merci. J'entends souvent aussi des patients parler d'immunodéficience, de dire qu'ils ont
I hear a lot of patients talk about other immune dysfunction. Is that the case for people that have autoimmune diseases? Do they have a weaker immune system? Are they more prone to have other infectious diseases, or is that not the case? That's a really broad question, and it's quite complex. There are some autoimmune diseases that can be associated with some dysfunction. For instance, in a very global nature, there's aging, and aging does lead to some dysfunction, and it can go hand in hand with autoimmune disease. So if you look at them in a combined fashion, it could lower immunity. However, if I'm looking at things now, of course, my experience is not in immune deficiencies, so that's something that's not really in the remit of what I normally do. So I can't answer that great question with great certainty. However, it's not impossible. That's what I would say. We do see a phenomena that have an impact on immunity, and it can cause deficiencies or dysfunction, but I don't really have any studies to point to that would say that either with GBS or CIDP, there's an immune disorder that's closely tied to it.
I would add to that there's no evidence that people with CIDP or GBS are more susceptible to infections or are at higher risk of a low immune system. It's the caveat to that being the medications that we use to treat CIDP can certainly make them more susceptible to infection by blocking their immune system, and specifically it's those who are being treated with corticosteroids that we see that in, and then to a degree those who are on azathioprine or mycophenolate or other agents like that. But the disease state itself of GBS, CIDP, or MMN does not put you at risk of being more susceptible to infection. That's been shown quite clearly.
Thank you. I think that's a question that'll put a lot of people sort of at ease when they think about their own condition and their sort of susceptibility and things like that. But it's true, it is a question that patients often have, and it's good to hear that answer. I have another question for Dr. Beaton. So should CIDP and MMN patients get referrals for physical and occupational therapy, just like GBS patients?
Absolutely. I think that this is a fantastic thing for their function, for their quality of life, and to maintain the strength and build strength back. So depending on where you're living and what services are available, many people won't be able to be followed forever by an occupational therapist or physical therapist through the public healthcare system. But anytime there's a flare, or even if there hasn't been a flare, there's kind of just natural aging that changes some of our function. I always encourage my patients to get what we call a tune-up. So our clinic is lucky enough to have a physiotherapist working with us, and they'll do, anybody who's newly diagnosed, they'll spend a lot of time with, and then for our chronic patients, they'll do a check-in every once in a while and update their exercise program so that they're doing exercises at home on their own on a regular basis. Things like optimizing balance, optimizing, your walking. Occupational therapists can be really, really helpful in adaptation strategies especially for things like MMN, where hand function can be so severely affected, to have tools to overcome some of the limitations of the weakness in hands and other strategies. I think that they're invaluable members of the allied health team, and I really do encourage everybody to have an assessment at least, and then hopefully you can take from that assessment some exercises or some strategies to do on your own at home.
And do you think that it's ever too late to start physiotherapy or occupational therapy?
I don't think it's ever too late to start, but the earlier the better, for sure. But there's always something that you can benefit from. Even those who have had, even my patients who've had CIDP for 30 years and they've adapted super well and they're very stable, that tune-up can be a real benefit.
Je voyais Dr. Piché-Martel qui dit n'importe quel âge.
Dr. Piché-Martel, I saw that you said anytime, any age, it's beneficial.
The next question is for Dr. Vassar. So my child has CIDP. What are some ways that parents can talk to their children about pain levels?
Well, thank you for the question. And I could talk for hours about pain assessment in our patients. And I think my colleagues here on the panel, they could discuss the same thing. But in children, it's maybe children know they something hurts, but the difficult part is to quantify the degree of the pain. And in teenagers, and maybe from the age of 10, 12, we can use the different pain scales, the happy face, sad face, or the scale of 1 to 10, but it's much more difficult to quantify pain in preschool children. So my approach, or our colleagues' approach, is to make it really relatively simple and go with the only, as opposed to 10 scale measurement, we go only mild, moderate, severe. And when we talk to children, the mild will be something like itch when you scratch your skin and it's itchy, so it would be a level of a mild pain. The moderate pain would be like a mosquito bite or even a wasp sting. And the severe pain would be really the severe dental pain. If the children has ever been to dentist, then they know what the severe pain is. So this is the way how you can probably approximate the level of the pain the child has. We know it's very subjective. So people, and even children, the teenagers, they may say my pain is 10 out of 10, and they are sitting next to me, not crying, not screaming, just, chatting. So keep in mind, it's a very subjective assessment. And even though you think that you know what the level of the pain is, it may not be exactly accurate. So, but for the preschool children, I would go mild, moderate, severe.
Mm-hmm. And you mentioned that pain is subjective. Earlier, we had a question about gabapentin and other medications for pain. So this is maybe a question for the entire panel. Are there things that you recommend to your patients other than, let's say, medications to treat their pain?
Well, we start with the medication, but we implement behavioral therapy, but it's a bit more complex, getting access from the pain clinic, and I suspect the same thing will be for my colleagues on the panel. But sure, there are ways to go with behavioral therapy to help with the pain. I don't know if anybody else wants to comment.
I totally agree. I think we have the pain clinics that we have out here in BC do a lot of work on, they do pain classes and talking about cognitive behavioral therapy for pain, mindfulness and meditation for pain, as well as gentle exercise and other approaches like this. The trick, as you already alluded to, is getting access to those places, because we've got, a very long wait list for the publicly funded pain clinics. We do have some sort of public-private partnership clinics where you can get some of the services more quickly, but have to pay for them, and so that's a real challenge. But certainly there's lots of great evidence for cognitive behavioral therapy in pain,
and it really helps. So if anybody can access it, please go for it, for sure.
And there are kind of apps that are designed for this as well, which are a little bit easier to access than the formal programs. So that might be something to look into if you're not able to access a formal program.
And obviously, apps you don't need a referral for, but our patients, do they require referrals for these programs? Do they require referrals for coverage? What is usually your approach to recommending those?
Yes, they have to be referred from the specialists for the pain clinic, for example, and it's a hospital-based service in our institution, so it's covered by the OHIP and hospital pay. I don't know in BC, but probably the same.
Yep, same in BC. I would mention, though, that cognitive behavioral therapy can be performed by many different practitioners, doesn't have to be hospital-based. And those ones are usually private pay, but anyone who has extended health benefits can usually get some coverage through that. But it's a lot trickier than the pain clinics, which have all of these services wrapped together.
Dr. Baudin, Dr. Piché-Martel, est-ce que vous diriez que c'est à peu près la même chose au Québec?
Dr. Piché-Martel, is it about the same in Quebec? In terms of access to pain clinics, it's very difficult in Quebec as well. Obviously, I think it's a bit of a challenge everywhere. It's something that the patients draw extreme benefit from. This multimodal approach has been proven to be very effective. For example, mindfulness therapy, cognitive behavioral therapy, those things are really useful. However, access can be extremely difficult and delayed.
Merci.
Thank you.
Donc, j'ai une question pour le
I have a
docteur
question for Dr. Piché-Martel.
des réactions indésirables chez les
Have we
patients
seen adverse events
ayant reçu un
in
vaccin
patients
contre
that
la
received a vaccine against COVID-19?
C'est une bonne question. Une
That is a
question
good
quand
question.
même, toujours d'actualité.
It's still a hot topic.
Cet historique, si
So,
je comprends bien la question,
if I understand the
c'est un
question
peu,
properly,
quel est le risque de développer
you're
un
asking what's the
Guillain-Barré
risk
si on a
of
le vaccin contre la COVID?
developing GBS if
Historiquement, on a
you
déjà
take the
associé
COVID vaccine.
Guillain-Barré
In the
avec
past, we have associated
certains
GBS
vaccins,
with
entre autres le
some
vaccin influenza.
vaccinations, including
Quand on
the
remonte à
flu vaccine.
posteriori,
Now,
ces
if you go
études-là
back
démontraient
in
quand
those
même que c'était
studies,
un très
it was
petit
it's
risque
a
d'augmentation de
very,
1 à
very
2 cas par
small
million de
risk,
personnes qui recevaient la
1 to
vaccination.
2 people
Pour la
in a
COVID,
million
on a eu,
that
on a eu
received the vaccine.
uniquement
For
certaines
COVID,
évidences que
there was
certains
some
des vaccins,
evidence
surtout les
that
vaccins
some
qui
of the
étaient
vaccines, especially
adénovirus et non les
the
vaccins à adénte,
conventional
pour l'instant, on utilise pour le
vaccines,
COVID, donc
not
les adénovirus, entre autres,
the
le Johnson
the
Johnson, on a
later
pu
developed
donner
vaccines, but
connaissance
the
de
Johnson and
celui-là ici au
Johnson
Canada.
that I think
Celui-là est
we didn't have in
associé
Quebec and
un peu
Canada, but
plus à un
so the
risque
conventional vaccines
d'avoir des
were a
Guillain-Barré, mais encore une
bit
fois, on
higher
parle
risk,
de
but
quelques cas de
we're only
plus
talking about
par million de
a few
personnes
more
vaccinées.
cases
Les
per
vaccins
million
actuels
people
de
that
COVID
receive the
d'ondes
vaccine.
ARN
So the current
n'ont pas
vaccines
des
that we're
études de
using, and
millions de personnes qui ont
we
été
have
vaccinées, là,
many,
des
many
15,
million
20 millions,
people,
certaines
up
études,
to 20
il n'y a pas
million
de risque
people
d'augmentation
that have
de
been
Guillain-Barré avec les vaccins.
vaccinated, and none of them have an increased
point à
risk
toujours
of
mentionner
developing
quand on parle de
GBS when
vaccination contre
getting
le Guillain-Barré,
the
c'est que
vaccine.
le
So
risque de faire
the
une
risk
infection, en
of
fait, le
the
risque de
infection,
développer un
we must
Guillain-Barré
be
avec l'infection contre le COVID
reminded
ou
that
l'infection de
the risk of the
Canada est
infection,
beaucoup
whether it's
plus
the flu of
élevé que
COVID
le
or
risque de
COVID, is
développer un
far
Guillain-Barré
higher
avec la
than
vaccination.
developing GBS through
Si je
vaccination.
reviens, parce que je suis pas
And
sûr du sens de la question
I'm not
exactement, mais
sure
dans l'autre sens,
where
c'est
the question
quelqu'un
was
qui a
going,
déjà
but
eu un
somebody who's
Guillain-Barré,
already
le risque
had
d'avoir une
GBS, the
vaccination après
risk
pour augmenter
of
les symptômes ou refaire un Guillain-Barré,
having symptoms
ça
after
encore une fois,
vaccination,
on a
that's
dans ce
something
sens-là un peu moins
that
d'évidence, mais en
we have
même temps,
less evidence
on
for.
dit qu'après
However, we say
quelques
that
mois,
after a few
3
months,
mois, 1 an,
3
selon les
months to a
sources,
year,
il
depending on
n'y
the
a pas de temps
sources,
limité d'avoir
you
de
shouldn't
recevoir
limit
un
yourselves
vaccin,
from getting a vaccine,
surtout si le Guillain-Barré initial
especially
n'était pas
if the
associé à un
initial
vaccin.
GBS
Ça,
was
c'est
not
plus difficile
associated
si
to
on
a
pense
vaccine.
qu'il était
It's
vraiment
a bit
associé
more
à un vaccin
complicated if you
seulement,
think
à
that
mon
perhaps
sens. Mais
GBS was
bon, on
associated to a
parle après un
vaccine,
3 mois,
but
donc quand on parle de la
after
phase aiguë du
the
Guillain-Barré, il n'y a
acute
pas
phase,
d'association
there
avec
shouldn't be
le
any
vaccin.
contraindications.
D'accord, merci.
Great,
Et
thank you.
la prochaine question,
And the
justement, est
next
pour le docteur
question
Baudin, qui
was
ressemble un peu,
for
c'est une
Dr.
question
Boudin.
qui est un peu plus
It's a
large.
bit in the same vein,
Donc,
but
qu'est-ce
a
qui
bit
pourrait
broader.
déclencher une aggravation des symptômes
What
comme la
could
neuropathie chez une personne rétablie du syndrome de Guillain-Barré
what could make
par le
symptoms
vaccin?
worse for somebody who's come out of GBS? Are there any things that could lead to a flare-up? Well, I think we have to draw a distinction between the normal evolution of the disease. For instance, after a few months, a patient might have some fluctuation in their health status. So we might think, is that a CIDP in the initial phases, or sometimes it's years later, somebody had GBS and they are fully stable, and all of a sudden there's a flare-up. So at that point, many things could explain it. There are many things we have to look at. For instance, there is a possibility of over the lifetime of having GBS in 5 to 8% of patients. 5 to 8% of patients will have a subsequent GBS episode. However, generally, it's an exacerbation because of a sensitivity. There could be underlying symptoms, for instance, tingling, numbness, that was still there, but a very low level. Those symptoms can fluctuate based on other factors. For instance, it could be the case with any systemic disease. people experience disease in a fluctuating manner over the course of their lifetime. You also have to think that there could be a new process as well. For instance, a patient who had GBS in the past that then develops diabetes or has chemotherapy to treat a cancer or takes a neurotoxic medication. They may have an additional neuropathy. Now, depending on how they recovered from the initial disease, of course, the nervous system was affected. They may have recovered fully, but over time, we may see that the degradation was sufficient enough for something to flare up in the future. But overall, it's quite broad, and I can't give you an exhaustive list of all the potential causes. Overall, the patients I see for GBS, when I see them during their last follow-up, I tell them, if you have future objectives or if you have new symptoms or flare-up of your current symptoms or previous symptoms, then call me back. If the symptoms are significant enough, then they should see their neurologist again for a reassessment. Thank you.
We now have a question for Dr. Beaton. Can CIDP affect cranial nerves, affecting, for example, double vision, cough triggered by swallowing, neck cramping, or hearing loss? If yes, is this a rare variant?
That's an excellent question. So the first thing I would say is yes, there are case reports of all of those. Well, actually, I would have to go searching for the hearing loss, but certainly there are case reports of all of those other symptoms occurring in the context of CIDP. But the presence of any of those symptoms would also make me think really hard about whether I had the right diagnosis. So this is if I see any of those things present, I'd really go back to the drawing board, start again with the history, kind of try and make my way through the whole kind of course of disease to convince myself that it is truly an inflammatory neuropathy or CIDP specifically. The presence of, for instance, visual changes or swallowing difficulties, these things can happen in hereditary neuropathies, for instance. They can occur in the context of other inflammatory disorders that can cause changes in the nerves, so things like sarcoid, for instance. And I would really be looking for any other atypical features to make me kind of doubt the diagnosis, if you will. So our current 2021 CIDP guidelines, that's in that sort of elucidated in the guidelines as well. So if cranial nerve involvement is there, you really have to convince yourself that they meet criteria in other ways in order to secure the diagnosis.
Thank you. And I think this may be our last question. So for Dr. Vassar, what are the chances of CIDP remission in children?
Thank you for the question. It's the CIDP in children and all the other autoimmune neurological diseases in children are relatively, compared to adults, are of relatively mild to moderate course. And many of the children being at CIDP, myasthenia, or even pediatric multiple sclerosis do quite well. And I would say definitely around 30–40% of children with, including CIDP, will get off the medication and will be in full remission. I don't follow them after the age of 18, so I can't say if anybody relapsed after the age of 18. The chance of relapse is obviously higher in somebody who had autoimmune disease in the pediatric age, but I can't tell you the numbers because maybe my colleagues will know how many of their patients presented in pediatric age and then were off medication in remission and relapsed later on. It happens, but I don't think it's maybe 5–6% max.
I think I only have 3 patients in my practice who had pediatric CIDP, and I have not seen relapses in any of them into their 40s and 50s as adults. So it's a very small number, but agrees with what you're saying for sure.
It's very rare to relapse after being in remission. And the longer the remission, the less likely the relapse is going to happen. So thank you.
Thank you. Thank you. So we maybe have time for one last question for Dr. Piché-Martel. C'est une question sur la MMN.
This is a question on MMN. I read that MMN is more frequently diagnosed in men than women. As a woman with MMN, I'm wondering why that would be the case. Do you have theories to explain why you diagnose it more in men? Well, this won't be a very long answer. Yes, we know there are a few more men, but I don't know that anybody can really give you a clear-cut answer. I looked because I wasn't sure if there was a theory. I didn't find one, but the figures, the frequency figures are quite old. If you look at the studies, they repeat the same thing, 2.7 to 2.3 more men than women, 2.3 times more men than women. So they weren't epidemiological studies, they were cohort studies, and they're known to have biases. So it's unclear.
Merci beaucoup.
Thank you.
Votre réponse.
Thanks for the answer.
C'est ce qui conclut donc notre
And so that
questions-réponses
will put an end
avec
to
notre
our Q&A
panel d'experts.
with our esteemed
So
panelists.
thank you to all four of you for participating in our Q&A. We really appreciate it. Our patients often come to us with questions and concerns, and we always send them back to you guys. So it's good to have you here to answer those questions live. And I know one of the challenges with our rare diseases is that we often don't have all our questions answered, but we hope that we'll continue answering these questions, and who knows, maybe one day we'll have an answer for why men are more likely to have NMN than women, and all the other questions that we asked. So thanks again for participating today, and thank you for continuing to care for our patients and our families. And we really hope that we can continue working with you for our future events with the foundation.
Thank you for having us.
Ça faisait très plaisir. Merci.
It was a pleasure. Thank you.
Thanks very much for having me. Bonne journée à tous.